Thanks for having us out here, guys. We appreciate it. We're at the Opelika Library. We're here from 9 to 11 for lectures if you're in the area. And then we'll have lunch about 11:30 and then skills labs starting at about 12 to 12:30. We're doing surgical airways. We're going to have mega code scenarios. The fire college is bringing their training bus down. And then we'll also do some ultrasound work as well. So that's the plan. For those of you online that are not familiar with EMS Challenge, we started this program back in 2014 to bring more physician-led Con Ed to the region and to the state. The Fire College started sponsoring us about 2 years ago, and we're able to get out on the road twice a month as well. We're currently reaching about 200, 250 people to lecture series, but I'll advise you that I think the lectures are okay. The skills labs where we kind of learn things. We bring the docs involved with this. It's a good way to ask questions, low stress, low key environment. So we also are sponsored by the Emergency Nurses Association of Alabama, the ENA, and we give nursing Con Ed as well. So thanks for the hospital folks that show up. For your certificate today, the Con Ed, if you're in the classroom, you just scan the QR code. We can get you that way. If you're online, you can use the chat box. There's a link in there. And if all else fails, if you're watching on your phone, just email us at alabamaemschallenge@gmail.com, and we'll get your certificate to you. Give us a day or two. Sometimes it takes a few days to run that through the system. But within 3 days, we should have your Con Ed out to you. If you participate with us and you watch half the classes we do over a 2-year recycle period, you got all your stuff for National Registry. For the EMS agencies that are looking for help with the Con Ed, this is a good way to get it. It's all free. It allows your crews to get the Con Ed they need, and you can use the time more wisely at station level to do hands-on training with your crew members. So. We're going to be at Centerpoint in June for a skill lab, just one lecture and lab in June to the World Games. Then we're going to start the regional pit crew CPR back at Brims after the World Games in July as well. Where we come in each quarter for each level, the EMT, the advanced, intermediate, and then the paramedic, and do out-of-hospital cardiac arrest training. In August, if you watch our website or Brims webpage of the Fire College, we're going to have a cadaver lab August 24th, 25th, and 26th. I think of the dates is on Wednesday, Thursday, Friday, and it's free. You can do chest decompression, IOs. We'll also have some donors. We can do surgical airways for those guys that are doing advanced practice now. So, I am not a graph and chart kind of doctor, so don't expect that, as you can tell by that inappropriate humor there. And I think Auburn's close to here, isn't it? Is that correct? Auburn? This slide is for you guys. Don't go to Alabama, right? They have great football, but the educational aspect's a little bit challenging, right? Cool. All right. Nobody even laughs. I thought that was funny. All right. New protocols came out March 29th, or excuse me, April 29th, right? I want to kind of touch base quickly on the scope of practice for the EMT. We used to call the EMT a basic EMT. We used to get a certificate that said basic EMT, and that is not the case anymore. There's nothing basic about EMT anymore. The work these guys do, they're the backbone of all EMS and healthcare. They're the backbone of the fire service as well. Our state's pretty progressive things that they can do. They can do blind insertion devices. They can do CPAP. You can do BiPAP if you actually have a ventilator form. So a lot of responsibility. And I say that because I think at the station level, the medics, the advanced EMTs should help the EMT out to get them skills where they need to be. In the past, you could take your EMT license and let it ride for 20 years and not ever touch a patient. Are y'all fully staffed down here right now? Today? Oh, praise God. Good for you. Not many people can say that, right? So everybody's looking for a new worker, a new firefighter, a new EMT. We got to train these folks up right. So glad to hear your staffing is better than most places. Anybody want to move to Birmingham and work with me somewhere? No. Take that as a no. Good. Thank you. That's right. I can get you hooked up anywhere in Birmingham. All right. So, but my opinions, basic EMT is not basic. If you look at the things they can do, the scary things are they're responsible for doing vital signs, appropriate history, and that stuff gets really, really deep. I mean, we train docs 4 years of pre-med, 4 years of med school, and there's no way in heck would that a first-year med student take care of a patient on their own. But yet we're taking the EMT, giving them 140 hours of clinical training, 48 hours on the street, and expect them to be held to the similar standard as us physicians. So again, just stressing this, we've got to take care of our EMTs. There was a EMT fire that delivered twins not long ago. He was pretty pumped about it. Yeah, afterwards, right? Who here's delivered a kid? Who enjoyed it? Raise your hand. We have one person that enjoyed it. Good. All right. I won't ask any more questions. All right. Anybody Talladega fans? No Talladega fans. That's kind of sad. All right. Fair enough. All right, let's get on to what else to talk about. We're going to talk about 12 leads. A lot of people get way deep in the weeds with 12 leads. My opinion, for what it's worth, a 12 lead is basically a screening tool. I get it. There are vectors, there are all those angles, degrees you got to memorize and learn at one point. But in reality, it all comes back to having a way to look at a 12 lead at 2 in the morning when you're on your second 24-hour shift and recognize STEMI or no STEMI. 20 years ago, it didn't matter. If you had a heart attack in the hospital, what did we do for you? We said, yep, you're having a heart attack. Here's an aspirin, cut out your cholesterol, going to give you some bad food to eat. We're going to put you on a lidocaine drip. So if you go into VTAC, maybe you won't die from that. And we're going to watch you for heart block. We can actually fix people with heart attacks now. There are people that have out of hospital cardiac arrest. We resuscitate them, get them to the cath lab, and they go back to regular work, doing full-time work, physical work a few weeks later. There's a firefighter in the Birmingham region, had an out of hospital cardiac arrest, big STEMI, got cath, doing fine. I can tell you stories and stories of that, okay? But the first point of contact is you guys. If you can't recognize a STEMI, we can't get them in the right system, get them to the cath lab or get them lysed, and people still die. So 12 leads are very important. I try to keep it fairly simple. Again, this is a screening tool. So I like American Heart when it says, is it too fast? Do you look, is it wide or narrow, regular or irregular? So ACLS I like. Our state protocols are good with this. With the too slow, I think about 3 things that cause bradycardia. I think about drugs, electrolytes, and ischemia. Drugs being blood pressure medicines, calcium channel blockers, beta blockers, things that everybody in the deep south is on, right? Everybody has hypertension and diabetes. Too much of those medications will get your heart rate slow. The normal amount of those medications, and you get dehydrated and have a kidney injury, it can make your heart rate get way too slow. So I think about that. Hyperkalemia. Hyperkalemia causes bradycardia and a Y-complex bradycardia, right? So, and then ischemia is the third thing. So somebody having a big heart attack. So someone who is bradycardic and symptomatic, they need a 12 lead real quick. You can rule out STEMI or no STEMI, and then determine, is it something else? Is it electrolytes or drugs? Now I get it. I know what you're thinking. People get bradycardic from other reasons. The 6-month-old that is blue, breathing 2 times a minute, heart rate of 40, what's their problem? Then it'd be bad. Yeah, they're hypoxic, right? Yeah. What about the dude shot in the chest talking to you en route to the hospital? Heart rate's 140. Now it's 130, it's 110, it's 90, it's 60, it's 40. What's going on with that dude? Yeah, he's dying. Hypovolemia, right? All those things you can pick up on your primary exam. You can see those things. You can touch the patient, figure that out. These 3 things you cannot. These 3 things, you need an EKG and a little bit of thinking to get that done. And then sometimes the more scary EKG complication is the okay-ish. The rates between 50 and 150, right? Is it a STEMI? Is it not a STEMI? Is there a long QT? Is there drugs going on? Functional use of AVR. We'll talk about that in a second as well. So that's the way I look at 12 leads, right? And again, you can memorize vectors all you want to. I have to go back when I talk to the docs to do a class with those guys every couple of years. I have to go back and relearn those vectors, right? Most of the stuff that I'm doing is memorization and having a way to look at a 12 lead every time so I don't miss something bad, so I don't feel bad about my life when I go home and I miss something. The first thing, you know how to calculate a rate. You can't just use the monitor, all right? You can't trust the paper that prints out. So calculate a rate, you're touching the pulse, getting a pulse rate. Then when you're looking for the heart rate based on the monitor, I use the box method. So QRS complex, 1 big box is 300, then 150, then 100, then 75. I don't care, I don't care, I don't care. And then I start thinking, wait, that's way too slow. Then I start over and actually count out and realize, okay, that rate's 43. That's way too slow, right? Cool. But you got to have a way to count. Intervals are very important. So the QRS, if you don't know what a QRS, normal QRS looks like, you can't determine if that tachycardia is a Y complex or narrow complex. If you don't know what a normal QRS looks like, you don't know if you have a Y complex bradycardia that makes you think hyperkalemia, and you should treat that right off the bat. All right, PR intervals. What does a long PR interval tell you? Y'all remember that from medic school? How many medics in here first before I start bugging people? It's a block. What kind of block is it? A long one. Yes, I like that. Long block. Yes, a first degree heart block, right? So what is a first degree heart block? What do you do for that? Anybody know? Anybody care? I know Chief Ward doesn't care. Yeah, we don't do anything for that, right? So first degree heart blocks, we're like, yep, you got a first degree heart block, big deal, don't really care, not gonna do anything for you clinically. But A long PR interval with a YQRS is almost diagnostic of hyperkalemia, all right? And if we miss that, somebody goes down a bad pathway, we can't get them back sometimes. Long QT, very important. The QT interval kind of puts you at high risk for having torsades, all right? So long QT, you can measure it out, but what I do is I look between the R to R, the QRS complexes. If the QT interval is more than half of that, it's too long, right? There are a lot of drugs that we carry in the pre-hospital world that prolong the QT. So if I had somebody that had a QT interval that's way, way long and they're nauseous, vomiting, got diarrhea, what drugs should I probably not give them? Anybody know? Zofran, yeah, Zofran prolongs the QT. So I've seen cases of people with long QT, they're malnourished, low magnesium. You give a little Zofran, and lo and behold, they go into torsades. It's a great rhythm. You get to do CPR, you get to shock them, you get to intubate them, but it's probably not a good idea for the patient to go into that for something that we gave them. What other drugs do we carry prolong a QT? Anybody know? Benadryl prolongs the QT, all right? And then anybody still using Haldol? Or y'all like patients? Yeah, both. Yeah. So Haldol is an old generation antipsychotic. It prolongs that QT. Ketamine's a lot safer for that, but remember, ketamine can get you in trouble legally sometimes. You got to be wise with your ketamine, right? Y'all been following the cases in Colorado about the guys getting criminally charged for using ketamine for restraint? Google that sometime. It'll make you think. So it's a tough crowd, Chief. Nobody's smiling at all. I guess I got to start telling inappropriate jokes or something. Yeah. All right. No, sir, that's not the point. No, I do not take that back. No. Remember, ketamine is ideal body weight, not total body weight. So it's based on height, not weight. If you're not sure how to calculate that, you can Google it. Or what I'd use to tell folks, just cut it down to 2 mg per kilo, right? So the guy that's 6'4" gets more than the guy that's 5'4", even if they both weigh 400 pounds. It's more height based. We got some information on that on our YouTube channel if you're interested. The other thing to think about ketamine use is if you give someone ketamine, they do not go to jail. They do not go anywhere else. They go to the ER, right? The biggest risk of ketamine is you give somebody ketamine is that they slow their breathing down or quit breathing. So if you give someone ketamine and they become hypoxic, you do not give them oxygen. And that's counterintuitive. If you give them oxygen, what's going to happen is you can give them passive O2. Their sats will stay up for 8, 10, 12 minutes. You think you're doing 5, you're high-fiving your partner, you're smoking your Camel Ultralight, right? And then lo and behold, they go into cardiac arrest. It's because they were not ventilating well and they're hypercapnic. So if they become hypoxic post-ketamine, you expose them, you look for life threats, you do a jaw thrust, you the airway. If that fixes the hypoxia, great. If that doesn't, you put in a nasal trumpet or an OPA and you ventilate with oxygen. You can't just give oxygen post-ketamine. That's a big failure, and that's litigated in the court as well. I can tell you, people like to look at charts with EMS or physicians that have ketamine outcome news these days, but different story. Thanks for getting me off in a tangent, Chief. Appreciate you. Yeah. So EKGs, I look at every EKG the same way. All right. So that way at 2 in the morning when I'm tired, I don't miss something. So I look at this when I say, is the rate too fast, too slow, or is it okay-ish? I use 50 to 150 as my rate. So I'm gonna look up there. If I'm gonna do the box method, is this thing up? Yeah. So 300, 150, 75, 60, yeah, I don't care. So between 70 and 80 is the rate. The machine may or may not agree with me, but I don't care. I'm also gonna be reaching down to my patient as I look at my EKG and I'm feeling the pulse rate. All right. All right, so I've looked, the rate's okay-ish. Now I'm gonna look for injury patterns because STEMIs are something we can fix. So I'm gonna look at leads 1, AVL, and 5 and 6. These are my lateral leads. I'm looking for ST elevation. If I got elevation in any 2 of these leads, that is a STEMI. If it's this one and this one, that's a STEMI. If it's this one and this one, that's a STEMI. If it's just leads, that's a STEMI. But looking for ST elevation there. Right? Those are my lateral leads. The next thing I'm looking at is my inferior lead, which is 2, 3, and AVF. So I'm looking for ST elevation, which is a STEMI. Now, if I see inverted T waves or some funky changes here, I'm gonna be concerned about the patient. I may move a little bit faster with them, but if it's not an elevation, it's not a STEMI. The next place I look is V1 through V4, and I'm looking for ST elevation as well in any of these. These are my septal leads. These are my anterior leads. This is really all the front and middle part of the heart, right? So I'm looking for elevation. That would be a STEMI. The other place I'm looking here is I'm looking for ST elevation. So, excuse me, depression. So ST depression, T-wave inversion in V2 through V4 is indicative of posterior backsided heart attack. Okay, if you go to some of these Life in the Fast Lane or EMRAP, they talk about you can do a posterior EKG to confirm this is a STEMI. And I can tell you from my practice in the ER, if I have this right here, machine may not say it, but this is a STEMI equivalent. I'm not going to spend time doing a posterior EKG. I'm on the phone with cardiology. Okay. My point to that is this is enough information. If this EKG prints out with your patient, you see this, and they fit the bill. They're short of breath, they're diaphoretic, they're weak, they're dizzy, or they have chest pain. This is a STEMI. So at this point, I move a little bit faster. Now they probably get supplemental oxygen or pre-oxygenation. I'm making sure they get the aspirin. All right. Are y'all in the STEMI system down here yet? I know that's going statewide. Not yet. I get blank looks. Thank you. Good. All right. Yeah. So the STEMI system is going statewide pretty soon, but that would just give us an opportunity to get to a place that either gives somebody a thrombolytic or a cath lab. And the last place I look is lead AVR. Now, for years, we taught that AVR was only good to make sure the leads were on correct. So if you're up in one and you're down in AVR, leads are on corrected. You can use that EKG to interpret what's going on. All right. In reality, lead AVR gives a lot of information. If you're elevated in lead AVR and you're depressed anywhere else in an injury pattern. So if I'm up in AVR and I'm down in 1 AVL and 5 and 6, or I'm down 2, 3 in AVF, that's a sign of a very close left main occlusion, almost like the Widowmaker. All right. So in 2013, they took left bundles off the indication for cath lab activation all the time and kind of made AVR that. Other cool things about AVR, you can look at it and use it for toxicology and some other things, but that's getting way too detailed. But AVR is the last place I look. So I'll take this EKG in a matter of 6 to 8 seconds. I got my hand on the patient's pulse. I'm looking at the patient. I've already got my history, and I'm looking at this 12 lead, and I run through injury patterns. Okay. The next thing I'm going to do is I'm going to look here in lead 2, and I'm looking for my intervals. That's a great place to look. I'm looking for my PR interval. It looks normal. QRS looks normal. Now I'm looking for my QT interval, right? So the T wave is less than half the distance from this to this. So my QT is fine. So this one looks great, okay? If the QRS interval is wide, I go over to V1, and we can talk about left bundles and right bundles. And that's something that probably wasn't taught when most of you guys went to paramedic school. It's core curriculum for that stuff now, because the way you look at a left bundle or a right bundle for heart attacks is a little bit different. But in the places that I'm overseeing, as long as we can recognize STEMI or no STEMI, that's a win for the patient there. So this one, I'll say the rate is okay-ish. The rate is what? 300, 150, like 112-ish or so. She says 107, who cares? I'm looking injury patterns, and I'm looking 1, AVL, got depression, T-wave inversion, lateral, that makes me uncomfortable. It's not a STEMI. 2, 3 in AVF, looks funky. That's not a medical term, but it's not a STEMI. V1 through V4, I got some elevation here. All right, so I go back and look at AVR. Then I look over here and look at my intervals. My PR interval looks okay. QRS is wide, so now I'll go over here and I recognize that this is a left bundle. Wide QRS, downward deflection. Now the cool thing about this is when your machine, my machine, any machine, when it sees a left bundle, it quits interpreting. It's not going to say STEMI or no STEMI at that point in the game. So now it's all on us to figure out, is this a scary EKG or not? Cool. Things that cause a left bundle, anything that jacks up the left side of the heart. So chronic causes, long-term hypertension, all right, makes the heart push hard against a high blood pressure. So this heart muscle gets big, it jacks up the conduction, stretches out the fibers, and it makes it longer for the heart to get that electricity. So you get that wide QRS through there. Okay. Key things about a left bundle is that QRS has to be greater than 120, has to be wide, and then I use V1. So if I have a downward deflection of V1, like you turn it left old school, that is a left bundle. If you see a left bundle on your EKG, again, the machine is not going to interpret that for you. So it could be an abnormal EKG, it could be a big freaking STEMI, the machine's not going to tell you. So at some point, you're going to have to figure out how to read and interpret those. And Dr. Brown will cover some of that this afternoon, too. Not sure why that slide is there. It's a cool picture, though. There's something called Scarbosa's criteria, a way to kind of look at the 12 leads in the left bundle to see if they're STEMI or not. Concordant ST elevation in any EKG left bundle or regular is bad. Concordant ST depression for the posterior we talked about, and then discord. Discord is good in a left bundle unless you get it greater than 5 millimeters. That's just a joke for the older folks in here. If you get that, you can laugh. If you don't get it, no worries. And somebody smiled. Good. Maybe you got it. All right. All right. Scarbosis. All right. And the reason I tell you this is because you cannot trust the machine on these things. We learned that in this movie in the early 80s. You cannot trust the machines. You cannot trust your machines on the LifePak or the Zoll. What do y'all use down here mostly? What do y'all have? LifePak, Zoll? No comment? Okay, fair enough. Anybody using the Tempest monitor? Anybody? Cool. There are a lot of monitors out there, but all of them are going to default when they see left bundle or right bundle and not give you a good answer, right? So this one, rate too fast, too slow, or okay? I say it's okay-ish, right? Machine says 95, that's all that matters, right? So 300, 150, 75, so it's in the 90-ish range, that's fine. 1 AVL, looks funny, but not a STEMI. 5 and 6, reasonable. 2, 3 in AVF, again, makes me uncomfortable because it got that T-wave inversion, but it's not a STEMI. V1 through V4, all right? I got this big ST depression T-wave inversion or biphasic here. That should make you sweaty and make you uncomfortable with your patient. All right, by definition, that's a posterior infarct, right? I'm still going to go back and look at AVR. AVR is opposite of lead 1, so it's a good 12 lead. I'm going to go back and look at my lead 2, and I'm going to say lead 2, the PR interval is fine. QRS is greater than 120, so I'm going to go look at lead V1. I know I got some kind of block, and this one points up, so this is a right bundle branch block. So again, injury patterns is the main thing to remember. 1 AVL, 5 and 6. 2, 3 in AVF. V1 through V4, this should make you uncomfortable. Then you can go look at AVR, AVR. And now I'm looking at lead 2, checking my intervals. I recognize my QRS is wide, so I go to V1. I'm pointing up like I'm turning right, so this is a right bundle. And in actuality, with a right bundle, you expect to see this T-wave inversion here. So this is probably okay. I would still rather somebody look at this, recognize right bundle or not recognize right bundle, either way, but recognize this is concerning and get this patient to an appropriate hospital quickly. Expedite care, right? Cool. What causes a right bundle is anything that jacks up the right side of the heart. So folks with congestive heart failure from hypertension, all right, the left side of the heart gets big, and then the right side of the heart will follow and get big. Folks who smoke, who have COPD, they get pulmonary hypertension, they get stiff lungs, they have interstitial lung disease. Folks who had COVID, spent weeks on the ventilator, now have some long COVID, they have increased interpulmonary pressures, so the right side of this heart gets really big, and you get a right bundle branch block. The other thing that can cause this is an acute PE, a pulmonary embolism. It causes increased pressure into lungs, so the right side of the heart gets really big, stretched out real wide fast, and you see somebody go from a normal rhythm to a right bundle branch block. That should be a big red flag. They got a big freaking PE. Questions, comments, statements within reason? Sweet. So back to the right bundle. So fits the build, wide QRS, upward deflection here. This is probably okay in a right bundle. If somebody called this and I woke up a cardiologist at 2 in the morning to come in to see this, I got no problem with that. They can be disgruntled all they want to. I'd rather us call this and it not be something bad than us not call it and not wake them up and somebody have a bad outcome, because we can actually fix STEMIs now. In the past, we could not. We can only fix them if we find them, right? This is a little diagram that I swiped off the interweb. It kind of shows you the location. So the circumflex lateral was 1 AVL, 5 and 6. 2, 3 in AVF is the right coronary or inferior. V1 through V4 is the septal anterior, the big portion of the heart. And then both of the main vessels come off the aorta, right? So if you got up in AVR and you down this way, it's a right coronary. If you up in AVR and you have depression laterally or anywhere through here, it's the left main coming off there. What's the problem if somebody has a big right-sided infarct? What's the issue with those guys besides them having a STEMI and maybe dying? What kind of symptoms would you might see for those folks? Blood pressure be high or be low? It's going to be low. The other thing is the SA node comes off right by the right coronary. So a lot of times these folks with this right side of the infarct will be in complete heart block. So they'll be bradycardic, hypotensive, right? Sometimes people tell you that you can't give nitro to people with an inferior or right-sided heart attack. And the answer to that question is if they're hypotensive and bradycardic, they don't need nitro, right? If they're hypertensive and having chest pain and having an inferior STEMI, they can take nitro, right? But if their heart rate's low, the blood pressure's low, no nitro for you. What's wrong with that picture? Yeah, can that happen? I don't think that can happen. Yeah, that's crazy. Yeah. So again, my point to this is if you're a medic or above, you should be able to read a 12 lead to look for STEMIs, right? Because we cannot trust the machines to do things. This is crazy. How did that even happen, right? And again, I refer you back to 1987 to remind you that we cannot trust the machines. All right, first case. This is a young dude, got palpitations. First response says blood pressure is 130/60. He got a D-stick, glucose, AccuCheck, whatever you want to call it. That's a vital piece of information. It's pretty important. If it says low, we know what to do, right? They get D50 or D10. If it says high, we know they're a diabetic and probably in DKA or something bad. If it says anything in between, I don't care. So if it says 300, yeah, that's me after 2 donuts. I don't care about that. If it says high, it's a problem. If it says low, it's a problem. Otherwise, it doesn't really matter. Breathing 24 times a minute, set 99%. They got a fast pulse rate, a little bit diaphoretic, and that's the 12 lead. So what do y'all think about that one? Too fast, too slow, or okay? Somebody please say too fast. Thank you. Good. All right. Yes. Roll Tide. All right. You make fun of them and I praise them at the same time, right? Yeah. Like a Baptist. Sorry. That was inappropriate. So too fast, right? Yes, way too fast. So my hands on the pulse, I recognize the diaphoretic. I'm calling for somebody to come start an IV access. I'm gonna think about pre-oxygenation. All right, they're not hypoxic, but they're high risk for decompensating. So maybe some pre-oxygenation before they go bad. I'm calling somebody over to start an IV on this person. I'm asking appropriate history questions as I'm doing all this stuff. I look at this 12 lead. I recognize it's too fast. So I'm not really gonna be concerned about injury patterns right now because that rate is way too fast. What does the machine say? 185. So I'm gonna say 300, 150, yep, between 150 and 300, that's too fast, I concur, right? Right, so the next question, is it wide or narrow complex QRS? Wide or narrow? Narrow, cool. Is it regular or irregular is the next question. Regular, how do you know if it's regular? What do you look for to look for regularity? Somebody says QRS intervals, I'll take that. What else can you do? It's easier. You can count the boxes, yeah. If I don't have my glasses with me that day, I can't tell you either one of those, to be honest with you. So the way I determine if it's regular or irregular is I reach down, I touch their wrist, and I feel. Or I dig through the bag, and I get that thing that's kind of dusty. That goes in your ears, and it's got a thing on the end of it. And I put it on their chest, and I listen, and I can say, is it regular or irregular? So touch the pulse, and it gives you regularity. Yeah, if you got great eyesight, go with it. QRS intervals, box-to-box method, whatever you want to do. Me, I'm gonna touch the patient, and that gives me a lot of information. If it's irregular, then I know it's one thing. If it's regular, it's probably what? What is this? SBT. Yes, SBT. Cool. So the next question would be, how do we treat this? So our protocols all went category A as of last month, right? So you can do whatever you want to. There's no call on the docs. It's all on you. So what are you gonna do to treat this patient? Blood pressure is stable-ish. They're breathing kind of fast. The diaphoretic, they don't feel well. They've been shotgunning Red Bulls, a little bit of cocaine. You know, it's football season coming up soon. That's okay. You can do that, right? So what are we going to do for this patient? Hugs, more cocaine? Is that what you said? Oh, good. I like this guy. That's good. Yeah. Yeah. Don't document that, sir. That'll get you in trouble, right? What are you going to do for this guy? Yeah. What kind of vagal maneuvers you like? Yeah. I like blowing. That's easy. Bearing down, yeah. Thumb blowing is great. It takes no equipment. You don't have to charge anything. There's nothing to resupply, right? And you feel pretty cool telling a grown-up to blow into the thumb, right? And you're the medical provider. Blow into your thumb, sir, right? Cool. What else can you do? He said have them bear down. I use that last because I've had people bear down before and they just poop right there on the stretcher or the couch. And I don't really want to deal with that. So you can bear down, but blowing the thumb is good. What else can you do? I don't want to know what you said. You can get out a syringe and have them try to blow the syringe, blow the plunger out. Okay, you can't do that. They don't know that. All right, it's a good vagal maneuver. Have y'all seen those YouTube videos where they're having them blow on a syringe and they throw them back and throw the feet up in there and do all that stuff? Have you seen those? What's that called, Dr. Brown? The modified something? I don't know. I don't know about you guys, but most of the patients I have are a little bit chunky, and there's no way I'm going to have them flop back on a stretcher or their couch and raise their legs up because if they fall on the ground, I got to pick them up, and I can't do that. You can if you want to, more power to you. Old textbooks talk about doing carotid massages. I don't do that either. In the pediatric world, the thing that fixes every SVT more than any drug is a rectal thermometer. You put a rectal thermometer in somebody's butt, they're going to vagal, and it would fix that. But one of my rules in life is I don't go near that orifice, okay, outside the hospital, right? Or even inside the hospital. That didn't sound good. But you know what I'm saying. I want to do that either. So I like your thought, blowing the thumb, right? So they're blowing the thumb, they're bearing down. None of that works. What can you do now? What'd you say? Adenosine. Yeah, adenosin's category A. You don't have to call, right? So we already went through that. We got this great flow sheet in our protocols now. Kind of tells you what to do. You can attempt vagal maneuvers, and then adenosine is the drug of choice. Adenosine is quick on, quick off. There's really no risk to it for the most part, except you're going to make your patient mad because they don't feel good when they take it. Who's given adenosine before? Who likes to give it? Yes, immediate gratification. It's sort of like giving somebody D50 or a paralytic. Something happens when you give it to them, right? Cool. So adenosine, 6 milligrams. How do you give it? Slow, fast, rapid. Do y'all do a push behind it, or do you squeeze the bag, or what do y'all do? Sometimes both. Yeah. So, you know, American Heart textbooks talk about you can do a 3-way stopcock. I get confused. I always screw that up. The point is you want to get the medicine in the patient quickly. All right. So you can push it and then flush behind it, or clamp off your tubing, push it, squeeze your bag, whatever it does to get the medicine in the patient. If you push the medicine and you see bubbles going up in your IV bag, what does that tell you? Wrong way. Yeah, it ain't going to work, right? So the medicine has to get to the person, right? So most SVT is a re-entry tachycardia. So the AV node's got some accessory pathway, and for some reason they got tachycardic and it screwed it up, and now they're in that loop, right? So too much Red Bull, too much cocaine, too much anxiety, something caused it, and they're in that narrow complex re-entry tachycardia. So the only people that I don't use adenosine for, I won't say the only, would be Y complex tachyes that are regular. American Heart says you can use it for SVT even if it's a Y complex. My argument for me personally is, well, sometimes I'm wrong and it's not regular. It could be irregular. And if I have somebody with AFib, RVR, and a Y complex QRS, they may actually have an accessory pathway instead of here, somewhere over here. And if I give them adenosine and I block this, they go from AFib to VFib. Now that's theoretical, and I get to do things like shock people and intubate and stuff like that if I do it, but it makes me uncomfortable. So I don't do it for Y complex QRS tachyes. Some physicians do. I've seen it given without problems, but for me, the places I work, we're not going to give it except for narrow complex, regular tachyes. So when you give your adenosine, you got to see something happen. If you give it and nothing happens, it's not working. I've given adenosine to a flutter, and I push the adenosine. You get that sinus pause. The patient feels like dirt for a second, and I see flutter waves, and I go, oh, that wasn't SVT. That was a flutter. No harm, no foul. I've given it for AFib that was narrow complex, and I've seen the AFib. No harm, no foul. But what you got to see every time is you got to see this kind of break here. Most people don't appreciate this. They feel like dirt. They get that impending doom. They get diaphoretic. The people watching the patient on the monitor freak out as well. So I always warn people. I usually don't warn the patient until after I give the medicine, though, right? So I push the adenosine. I say, you can feel like dirt for a second. Sorry, right? And they kind of groan. They cuss. They feel bad. Everybody freaks out. You see this. And then hopefully what you see is you see them go into a nice little sinus rhythm after that. But if you don't see an EKG change, the medicine did not work. So if you give 6, nothing happens, what do you do next? 12, right. Nothing happens, what do you do? You can do 12 one more time, right? If that doesn't work, what do you do? Kapow. I like him. Kapow. You could kapow, or you can go back and think, why in the heck did that dentist not work, right? So make sure if you're doing that, you go back and make sure that the EKG did change. If not, it didn't get to them. If one of your doses did not cause them to break down for a second, that dose is a gimme. You can mark that off. You can repeat that dose without calling, okay? Fair enough. So adenosine, pretty good drug. Obviously, if they become unstable, altered, hypotensive, you get kapow. But to kapow them, you got to have the leads on them and the pads. It's got to be synchronized. You can't just zap them. There's a difference between kapow and zap, right? Cool. I would argue most folks in adenosine, you got time to start IV access and give adenosine even if they are symptomatic. But if you don't have IV access, kapow. All right, how about this one? This is EKG off a triage patient that I had working down south a couple of years ago. But I've seen the same thing given to me by urgent care. Or I shouldn't say that. By yeah, too late. And they're like, this patient is doesn't feel good. They're short of breath. They need to go to the hospital. And then you go into the paper, and this is the EKG. And it's like, that's the reason they're short of breath. They don't feel good, right? So what is this? It's VTAC, right? Cool. Are they alive or dead? How can you tell the difference on this one? Yeah, check a pulse. Yeah. Well, it's a 12 lead. Only an idiot's gonna do a 12 lead on a dead person. So I'm hoping they're alive, right? If it was a rhythm strip, you don't know. But a 12 lead, this VTAC, I bet $3 they're alive, right? Cool. So you can go through the mnemonics, too fast, too slow, or okay-ish. If you have to, you've probably been working too long. Wide or narrow, is a Y complex QRS, regular or irregular. I'm gonna reach down and touch the pulse. Hopefully they have a pulse. American Heart has all these definitions of stability, right? So they have chest pain, they have shortness of breath, or the diaphoretic. And I bet my $3 that I got that any patient in VTAC is going to have one of those complaints. There's no way they're not going to have a complaint. So by American Heart definition, they're unstable. They get kapowed. Okay. What I would argue is that I'm probably going to determine are they unstable by altered mental status before I kapow them. People don't appreciate being synchronized cardioverted if they're awake and alert, okay? So if I got a guy talking to me, sitting on the side of the bed, diaphoretic, got a palpable radial pulse, I know his blood pressure is probably 90 or better, all right? I'm probably gonna work on IV access, putting the pads on the guy, I'm doing pre-oxygenation, and I'm gonna consider medications before I synchronize cardiovert him. Now, same dude is sitting there slumped over, not breathing well, really won't wake up and say much to me. I'm not going to do all that. I'm going to put the pads on him, put the leads on him, hit sync, charge, lay him back clear, and kapow him. I'm going to use mental status as my determination. Do I use electricity first or electricity first? Okay. What drugs can I give this dude? What do y'all carry? Amiodarone. Yeah, so amio is a great drug. It works for any kind of tachy. Amio is probably, it may be a little bit more expensive than lidocaine, but you can use amio for VTAC, for VFib. You can use it for A-flutter, for SVT, so it's pretty versatile. So amio is a good drug for this guy. What else could you carry? I think I just said it. Lidocaine. Anybody carry lidocaine? Yeah, so lidocaine's reasonable too. I still like lidocaine. In the hospital, we used amio for years. Somebody must have paid AHA off to get, I shouldn't say that either, to get amio approved for everything. But amio has a lot of pulmonary effects, so we don't use it long term anymore. And I hardly ever do drips on these people, but amio or lidocaine. Okay, so self-sedated is my key where I use electricity or not use electricity. Okay, red flags with VTAC is rates less than 50. So a rate less than 50 makes me think maybe it's not VTAC, maybe it's that A-flutter, AFib, or SVT with aberrancy, or maybe it's something else. So like this one right here. So machine says the heart rate's 267. This is a dude, keeps saying Earl. He's breathing really fast. He's satting fine at 99%. Do y'all have waveform capnography, nasal capnography here? Are y'all using that? Oh, good. That's like cheating, man. That and the glucose gives you a lot of information. So his blood pressure is soft at 90. His end-tidal CO2 is 12, and his glucose reads high. and this is his EKG. So too fast, too slow, or okay? It's fast-ish. Machine says it's 267. Do y'all believe that? No, what's the rate? What's half of 267? Like 130? Yeah, machine's reading this T wave in this. So that's what the machine's reading. But that's the QRS, that's the T wave. So the rate's actually half. If you lay hands on this patient, you're going to recognize that's not 260. This patient got to the hospital I was working at, the doc saw this on the monitor and that blood pressure and was like, put him on the pads, fixing to kapow him. I'm like, nope, he doesn't need kapowage, right? I didn't really say that then, but I say it now. So, right? So what's going on with this guy? What's his problem? You can diagnose it by this EKG and those two things. What'd you say? He's not hypoxic. His stats are 99 cents. Yeah, his end tidal's way too low. He's breathing fast to blow off, so he's acidotic. This is DKA. I don't need any other blood test or anything else. So he's acidotic, not hypoxic. His glucose is high, so he's in diabetic ketoacidosis. We got peak T waves, and we got tachycardia, so it's dehydration. So EKGs can give you a diagnosis of other things besides STEMIs. So had we synchronized cardioverted this guy, what would have happened to him? He probably would have died, right? He's hyperkalemic, he's acidotic. I sync him, I shock him. Now he goes into VFib. Now I give him amio, I give him epi, and I never give the appropriate treatment. So that should be an easy pickup in the future for hyperkalemia gone wild. Most time hyperkalemia is slow and wide. That's fast and wide. So back to that, we kind of talked about lidocaine versus amio. Either one is reasonable. At any point, if they become altered, they get synchronized cardioversion, regardless of the medication you gave them, right? This is Chief Ward's favorite picture right here. This is him. This is one we just happened to catch going to the VTAC on the monitor. Go back and forth. Sometimes it takes more than one kapow to fix them, and that's okay. All right, this is an older guy at Walmart. Actually, he's a young guy at Walmart, right? He's passed out. He's awake alert. He's got some dyspnea. He's a little tachy in the 112s. He's sat in 93%. Blood pressure is 110/60. I would argue that in Alabama, that's hypotensive. Nobody in Alabama has a good blood pressure like that. Mine's never that good, even with medicines. The breathing fast at 22 a minute. AccuCheck is 214. So according to my rules, I don't care. Got a history of hypertension and COPD. He says that he had recently started some antibiotics for his leg. He's got cellulitis. His wife made him get back on his blood pressure medicine. He's been weak for the past couple of days ever since he restarted that. And today he was just hanging out at the Walmart and passed out. That's his leg. He's a big dude, big legs. That's his EKG. Too fast, too slow, or okay? It's okay-ish. It's between 50 and 150, so okay-ish. And now I'm gonna start looking at injury patterns. So I'm gonna look at leads 1, AVL, and 5 and 6. Looks a little weird, but not a STEMI. 2, 3, and AVF. Again, looks weird, but no true ST elevation. V1 through V4. I got this depression here. So this again kind of goes back to what we looked at earlier. It makes me think posterior. I look at lead AVR is opposite. Now I'm gonna go back and look at my intervals. Peer intervals maybe a little bit long, but not crazy. QRS, a little bit wide. So I go over here and I'm pointing up. So this is kind of an incomplete right bundle branch block. So he's got signs of a right bundle. He's hypoxic. He's hypotensive, and he passed out. What could his causes be? What could be his issues? What would y'all think about causing this? A lot of folks say, well, he passed out because he just started his blood pressure medicine again. He's hypotensive. Yeah, could be. People say, well, he's short of breath and hypoxic because he has a history of COPD and he's sick. Maybe he's septic. Yep, that's true. It could be. But if I tell you I got a, what'd you say? Yeah, PE. Yeah. So we think different than other type of healthcare providers. Everybody else starts at the lower tier and works their way up. That's not what we can do. We think about the things that kill you dead now and get the other things later. So I got to do with the swollen leg. I don't care if somebody said it's cellulitis, who passed out, who is now hypoxic and tachycardic and has a right bundle branch block. He's got a PE until proven otherwise. Because if we miss that, he's going to die. Good call. PE. Yeah. Oh, that's a better EKG there. Right. Textbooks talk about PEs. You get a S1, Q3, T3. So you get a S in lead 1, a Q wave, and an inverted T wave in 3. Yeah, that's there. And about 25% of the people that got PEs and about 25% of the population that don't have PEs have it too. The more concerning thing is tachycardia, right bundle, and its history makes you think, okay, I just diagnosed a PE. So when you get to the hospital with this patient, if you're waiting on the wall, if you're not waiting on the wall, y'all don't transport, do you? Y'all transport here? Oh, roll, that's good, good. Get ready for it. It's coming. That was a joke. Or not. Wow. I think somebody just cut my tires in my truck. This is the patient that when you get to the hospital, you notify somebody, hey, I got this old guy, and you don't give them all the history of COPD, hypertension, the hypertension. You say, hey, I got an old dude that passed out, that's hypoxic, got a swollen leg, and a right bundle. That physician should say, oh crap, that's a PE. Should get up and follow you to the patient and look at that patient, okay? Because we don't want that patient to die in our ER either. Makes us look bad. Nah. We talked about right bundles already. I'm not sure why that is there. Bonus slides. Yeah, so potential. So he could be dehydrated. He could be hypertension to his medicine, cellulitis, sepsis, COPD. Man, all that doesn't matter. What matters is we think this guy's probably got a PE, right? If he's got these other things, we can fix it with our fluids when we get to the hospital. If he doesn't, we got to be aggressive and treat that PE, right? So don't let the lots and lots of information that we get from patients mess with you. Look at the things that matter. Figure out what's important, what's not important, and move into things that are important. Bacon is important. I like bacon. All right. So blood clot PE, basically what you do is you get a clot that comes from your legs or somewhere else in the body. It goes to the right side of the heart, then it gets pumped into the lungs, and the lungs work as a filter. And it just catches that clot, and then everything distal starts to die. That's why they have chest pain. That's why they get tachycardic. That's why they get hypotensive, right? The way we diagnose it in the hospital clinically, chest x-rays don't tell us anything. We get them because we're looking for other issues. Is there a collapsed lung, a pneumonia, something else we can treat? CT angio is the gold standard. We used to do pulmonary angio. We put a catheter in somebody's groin, squirted dye there, and got angio. Now we just use CTs. The problem is that currently there's a national backorder of contrast for CT angios. So some places, some hospitals can't even get a CT angio right now. So we have to diagnose this by history and the same information that you have. You can do a VQ scan. It's an inhalation exam. When you inhale some kind of radioactive isotope, that sounds horrible, doesn't it? All right. And you look to see if somebody has a probability of having a PE. If RADS reads it as high probability, there's about a 9% chance they have a blood clot in their lungs. If it's normal, they got about a 5% of having one. Most of the time with Alabamians who already have underlying heart and lung problems, they read it as a moderate risk. So that tells you that they got a 50% chance of having a PE. And does that help you? No, that gives you no information whatsoever. Cool. This is a CAT scan of somebody with a blood. Looking at this, the head is going toward the wall, their feet are out, and they're looking up. This white stuff is that contrast, which we don't have right now in American healthcare due to shortages. That's blood, and we can see that the blood is not moving beyond this thrombus. So this whole lung is not getting perfusion. So that's why they're hypoxic, that's why they hurt. If this stays that way long, this lung tissue starts to die off, it gets necrotic, very bad. The hope is that this starts to dissolve pretty soon and we get some blood flow distally so that part of the lung does not die. This is a saddle PE, you may have heard of that. That's where the clot is over the break where it goes to both lungs. These are the people that die quickly. So this is the person that has a big saddle PE. They pass out because they have no perfusion to the lungs. They hit the ground, part of the clot breaks away and floats downstream, and they wake up again. Now's our chance to recognize what's going on and potentially fix this, or next time they pass out, they don't wake up. There's more CAT scans kind of showing the PEs. So what we do for these folks is we give them blood thinners. Sometimes we'll give an aspirin and then another antiplatelet medicine. We can also give them the same drugs we give for strokes, TPA, to kind of dissolve that clot. More importantly, we usually give them stuff like heparin, Lovenox, and that makes that clot not get any bigger. That's the purpose of that. If they're completely unstable, hypotensive, altered, if we have to intubate them, if they go into cardiac arrest, then we're doing the same kind of therapy like we do for STEMIs and for strokes. We're pushing TPA, which is never a good day for anybody. But the way heparin works and all these blood thinners is it makes that clot not get bigger so the body can reabsorb it. The TPA for strokes and heart attacks will go in and break that clot down. Problem is, we break this clot down, these little clots go downstream, and you'll still have microinfarcts in the lungs distally, but it's better than having it proximally. That's what kills people. Years ago, the way we fixed blood clots is we went in surgically, opened the chest up, opened up the vessel, and pulled this clot out. How many folks do you think survived that surgery? Yeah, not many. That's a bad day. So we got much better success using the thrombolytics. A lot of hospitals have PE teams now, PERT teams, where they have interventional cardiologists that can go in with a wire and squirt TPA close to this and help them out. I foresee in the next 10 years that we have PERT response hospitals, just like we have STEMI hospitals and stroke hospitals, but we're not there yet. We got about 4 minutes so we can get to this case. This is a older lady that was playing in the yard with her grandkids. She passed out. CPR and called EMS. EMS gets there and the chick's sitting upright talking to them. They're like, "Why did you call us? You didn't really do CPR." Nobody gets CPR and then wakes up, right? So what do? You do what we're supposed to do. You do a quick assessment, hands on the patient, getting your ABCs, getting appropriate history, doing an exam, doing a 12 lead. Here are our vital signs. Pertinent questions: are you a diabetic? Are you on blood thinners? This ever happened before? Okay. She said never happened before. She's got good distal pulses. Breast sounds are clear. 12 lead looks normal, but she's got a murmur. So what the crap? So who actually listens to murmurs for murmurs? Raise your hand. Yeah, me neither. I don't do it either. Yeah, only 3 times do I listen to murmurs on patients. If they pass out, I get the stethoscope and I listen for a murmur. If they're having a STEMI and their blood pressure is low, they look like dirt, I'm thinking you're fixing to die, dude. I'm gonna listen for a murmur. It matters there because they could be having a STEMI, and if I got a murmur and they look sick, maybe they ruptured a valve and they need a cardiothoracic surgeon, not just a cardiologist. All right. If they pass out and they have a murmur, it makes me think of one of 2 things. If they're older, I think of aortic stenosis. That's very common that people get aortic stenosis. They start exercising, working out, dancing, partying, doing whatever they're doing late at night, right? And they pass out. And then they wake up again. It's kind of a sentinel event before they go into cardiac arrest. So, oh, there's a cat video. I almost forgot to start it. Y'all got a cat at the fire station anywhere? Anybody? No? You need a cat, man. So that's the 12 lead. It was non-scary. I showed the video. So aortic stenosis. Basically, you got an aortic valve that's jacked up stenotic congenitally or just from hypertension, or maybe they were an IV drug user years ago, they had an infection. Now that valve is messed up, so they start doing some kind of exercise where they have to increase their heart rate and get cardiac output through there, so they pass out. So syncope and a murmur is concerning. You know, post-cardiac arrest and a murmur. Those folks need to go to the hospital because what happens next time, if family is not there, the patient will actually die from that. If it's a kid, if it's the 14-year-old kid, it's not aortic stenosis, it's hokum. That's the case that you see on the news every couple of months. 14-year-old playing basketball or playing football, passes out, they do CPR, they shock them, and they die. They had hokum, and that's hypertrophic obstructive cardiomyopathy. And I can't spell any of those words, okay? But the point of that is this left ventricle is really, really big, and so they get increased cardiac activity. They can't pump enough blood, so they pass out, they go into VFib, and they die. So syncope and a murmur needs to be evaluated. That's murmuring. The Egyptians, remember that from Bible school? Yeah, okay. A few of y'all smile. All right, fair enough. That's American healthcare. We are EMS. That's what they're saying to us. I get it. And then I got 3 rules, and I know if you watch online, you've heard these before, and you're probably tired of hearing this, but these are kind of corny but serious. The first rule I have is I don't want to kill people. You go to prison for that. You feel bad about it. But the medicines you guys carry, the responsibility you have now, especially with everything Category A, is pretty high. The public expects perfection. The healthcare is going to hold you to the same standards they hold me to. It's not fair, but it is what it is. So the way I don't kill people is that I'm always training. I'm thinking about what I'm going to do on the next call. I know medications that I have available to me. I know what the contraindications, the indications for them. I know when to defibrillate. I know when to synchronize cardiovert. I know when I know what I don't know. So I know that I don't know what the heck's going on, so I'm not going to do anything. I'm going to move you to the doctor that can help you, right? I can recognize somebody with a head bleed, subarachnoid hemorrhage, subdural hemorrhage. I can't take them to the OR. If I do, they will die, right? But I can recognize it and say, okay, nothing I can do. I'm going to get you to the right place. And that's what you guys got to do. So I don't want to kill people. I try and help folks. A lot of the stuff we see is BS. I can't say that probably, but there's a lot of emergency response that is not emergency. So I try to help folks if I can, all right? And the third one is probably more important, is let's go home with a clear conscience. So if I don't kill people, I usually sleep good at night, all right? When I make a mistake, I don't sleep good at night. But the way I address that is I go back and I look at what I screwed up and I figure out my deficiencies and I go back and I train on that, because we're not working at Walmart here. We're working with people's lives. And sometimes it's your friends' lives or your family's lives. Sometimes it's your own kids' lives that you're taking care of. So pretty important stuff. This picture here, I put this up there because you see that says doctor, and look at those arms. That's me. That's at Five Below. You can get those at Five Below. That store, you got a Five Below down here? Yeah, they got those. Yeah. This is my example of EMS, right? So calling a EMS provider, a healthcare provider, is like calling this dude a day laborer. All right. The job's a little bit more challenging than that. And we, as the hospital staff, the physicians, the nurses, healthcare as a whole, we should be the ones supporting you better than we are. All right. And I'm not sure what that picture's in there for, so we'll skip that one. You can't miss big EKGs. If you miss this and somebody sits in the wall of the hospital for 30 or 40 minutes, they die. And you just took somebody's husband, wife, son away. Big freaking STEMI, should not miss that. Complete heart block. Again, you don't have a systematic way to look at these EKGs, you're going to miss this. Again, bad outcome if this is not addressed pretty quickly. People die from that. This one's a little bit more challenging, but you shouldn't miss it. This EKG will lead to this pretty easily. What's the QT interval? Machine says it's 751. Don't know what that means. What I do know, QRS, T wave, P wave. They're making out. They should not make out, right? That QRT interval is way too long. This patient, high risk for going into torsades, right? You shock them, you give epi, you give amio, it doesn't fix. What drug do they need? MAG. They need a bunch of MAG. State says 2 grams. I'd argue they need more. They need at least 2 grams. And then this one. Question of this one is STEMI or no STEMI. Machine says no STEMI. Dude's fine. Yeah, I know you're having some chest pain. ER's full. COVID's bad. I want to go to the hospital tonight. You'd be waiting for hours to be seen. Guy takes your opinion and goes home. And he's got this EKG. He dies. It's a big freaking STEMI. The machine won't even tell you. So that's all I got. Let's take about 5 minutes. Then we'll come back with Dr. Brown and do hers, and then we'll do skill lab.
Hey, Dr. Ferguson, we do have a couple of questions. So somebody was asking, syncope is related to pulmonary embolism, so we understand why they pass out. We just don't understand why they wake back up.
Yeah, so the thought is that they have this big PE, and they pass out because of that, and they hit the ground, and part of that clot dissolves and moves downstream. So part of the lungs that were not getting oxygen and blood supply can now get that. That's the thought behind that. And it's just a thought.
Great.
Yep.
Thanks. Great session, everybody. We're going to take 5 or 10 minutes. Come back. We're about to get started with Dr. Julie Brown. She has a lecture for us today on acute coronary syndrome. She's going to go a little bit more in depth on some of the 12-lead EKG interpretations. And it's a good lecture. Thank you, Dr. Brown, for being here.
All right, y'all, we'll get started again. So I'm Julie Brown. Like Dr. Ferguson said, so I'm an ER doctor at UAB as well, but I'm doing an extra year of training in EMS. So next year I'll be faculty at UAB, but doing a lot more with EMS as well. So we're going to talk about ACS, or acute coronary syndrome. Dr. Ferguson talked about some of the things we're going to talk about, but we're going to go through it in a little bit more depth than he did, and go through a few more EKGs. If y'all have any questions, or if I talk too fast, I have a tendency to do that, please just stop me or tell me to slow down, okay? All right, so we're going to talk about a little bit of intro, some of the definitions or the types of ACS that you've probably heard of, the signs and symptoms to look for, go through some EKGs, and we'll talk about treatment. All right, so why do we even care about this? Like, why are we even talking about ACS? So in the US, someone experiences a heart attack every 26 seconds. Like, that's really often, right? And it claims one life each minute. So somebody dies from ACS once a minute in the US. Like that, as long as I've been talking, somebody's died from a heart attack. And about half of those who suffer a heart attack or an acute MI, so MI, myocardial infarction, use EMS, right? And how many other patients do you see with chest pain? Probably a lot of the patients that you see, right? So a lot of them use EMS, so that's why we care about it. All right, so coronary artery disease really causes over 1/3 of the deaths in people over the age of 35. So I'm almost 35, and so that's going to cause 1/3 of the deaths over my age soon. It's the leading cause of death in that age group, and over 18 million people in the US are affected by it. The incidence is usually higher in men, but as males and females get to the age of 75, it becomes a little bit closer. And then the risk factors we think about are those who are obese, people that have diabetes, people that have high blood pressure, HLD is hyperlipidemia or high cholesterol, people who smoke, people who use cocaine or amphetamines like meth, those that have family history, people who have chronic kidney disease or dialysis, ESRD, are at high risk. Those who have HIV, autoimmune disorders, so anybody who has a chronic inflammatory condition is at high risk for having coronary artery disease, and then those with anemia. All right, so what is ACS? So it's really a spectrum of conditions, but it essentially involves any kind of acute myocardial ischemia, so heart damage from a reduction of blood flow, right? So there's 3 different presentations that we think about that we really care about. So unstable angina, STEMIs or non-ST elevation MIs, and then ST elevation MIs. We'll go through all this. All right. So unstable angina is when a patient has ischemic symptoms. So they have chest pain, they have shortness of breath, but their EKG is usually normal. And then they come into the hospital and we get a troponin on them, which is the lab test we get that's just a marker of heart damage. And that's usually normal. But these patients usually have, you can see they have a plaque right here in their blood vessel. And so when their heart needs more oxygen, so say they're exerting themselves or walking to the mailbox, they're unloading groceries, they need more blood flow. And because of this plaque, that blood flow can't get past it. So then they get chest pain. All right, and then an NSTEMI is when a patient may or may not have chest pain, but they have an elevation in their troponin in the hospital, which obviously aren't going to see in the pre-hospital, but we'll see an elevation in their troponin in the hospital. Their EKG may or may not have any changes. So you might see ST depression, like this right here, or you might see some T-wave inversion, or you might not see anything. Types of NSTEMIs, which is why I said that they may or may not have chest pain. So the most common one we see are type 1 NSTEMIs. And so what this is it's caused by coronary artery disease. So a patient has a plaque, and then that plaque keeps building up and building up until they have ischemia in part of their heart. So then they get chest pain and an elevation in their troponin, may or may not have changes in their EKG. But we can also see another type, which is type 2. And this is usually due to an oxygen supply-demand mismatch. So that patient who's septic, who has a bad UTI, a bad skin ulcer, and they're unable, but they have coronary artery disease, so they have plaques, and they can't meet that demand. They can't get the blood flow to their heart fast enough. So that's not really because of the coronary artery disease. This is really because of something else. So they're septic, they have a fever, they're tachycardic, and now because they're tachycardic, they can't get enough blood flow to their heart. The type 3, you're never really going to know about, you're just going to suspect it. So those are those cardiac arrests that you get called out to, like a 60-year-old man who had chest pain and then collapsed and you never get him back, okay? Or female, you know, whatever. Those are those people who die because of a heart attack. And you may never get an EKG, they may never get ROSC, and so you'll never know that they had a heart attack. And then there's a couple other types. Type 4 are usually associated with PCI, or percutaneous coronary interventions. That's the procedure we do to reopen the blood vessels in the heart. Or type 5 is after a CABG, which is open heart surgery. So those are the two types we don't really see. All right, so then we'll talk about STEMIs. So those are the patients who have ischemic symptoms, chest pain, shortness of breath, dizziness, lightheadedness, diaphoresis. Their biomarkers are elevated. This is kind of plus minus. Sometimes if the patient get to the hospital fast enough, their initial troponin might be normal, and then a couple hours later it'll be elevated. And then these people have EKG changes, which we'll talk about. All right, so this is just kind of all of the types. So we have unstable angina, which they have chest pain, their troponins are normal. They may or may not have EKG changes. The NSTEMIs, which is ischemia, but not all the tissue is dead. It's only part of that tissue is trying to die. So they'll have an elevated troponin, may or may not have EKG changes. And then the STEMIs have elevated troponin and have that ST elevation. All right, so signs and symptoms that we're looking for: chest pain, shortness of breath, dizziness, lightheadedness, syncope, near syncope. Someone said, I feel like I was going to pass out. Nausea, vomiting, diaphoresis, anxiety, a sense of impending doom, palpitations, and then obviously cardiac arrest. So if you get ROSC on a cardiac arrest patient, what's one of the first things you want to do? Get an EKG, yeah, get a 12 lead. Because we want to know, did they have a cardiac arrest because they're having a STEMI or not? Do we need to take them to a PCI hospital? And these are all important to think about, because that 78-year-old female that comes in having a STEMI may not present with chest pain. She might not have chest pain at all. She might just feel a little bit weak. She might have a little bit of nausea and vomiting. All right, so what are things that increase our likelihood of having ACS? So those are the patients who are having chest pain that's radiating down both arms, chest pain that's radiating down the right arm or the left arm, chest pain that's associated with diaphoresis or sweating, chest pain that's associated with nausea and vomiting, and then chest pain with exertion. So, and that exertion can be just walking to the mailbox. And then factors that decrease the likelihood of having ACS would be pleuritic chest pain, so chest pain that they have when they take a deep breath, positional chest pain, if it's described as sharp and stabbing, or if it's reproducible with palpation. I'm not saying that patients with STEMIs can't have these symptoms. They can have reproducible chest pain. You can still always worry about it and get a 12 lead, but these decrease that likelihood. Okay. And then there are some factors that are associated with a delayed presentation. So in general, females usually present later because they try to, walk it off. They say, oh, I'm fine, nothing's wrong. Okay. Those patients who are older, patients who are Black or Hispanic are more likely to present later. Those who have a lower educational achievement or lower socioeconomic status. So these people are going to get to the hospital or to their medical care provider later. And then women, bless y'all, women who have ACS are less likely to be treated with guideline-directed medical therapies. They're less likely to undergo cardiac cath and less likely to receive timely reperfusion therapy, so a PCI, to open up that blood vessel. And that might be because they just stay at home longer and they don't present to the hospital fast enough. But these people are also more likely to report fatigue, shortness of breath, indigestion, nausea, vomiting, palpitations, or weakness. So we might not think of them having a STEMI, right? We might think, oh, they just they're weak today, maybe they're septic. Okay. All right, so now we're going to talk about STEMIs. So to diagnose a STEMI, you have to have at least 1 millimeter of ST elevation in any 2 contiguous leads. So it can be, we'll talk about all the leads, but it can be in 1 in AVL, it can be V5, V6, it just has to be 2 leads. Except in V2 and V3. So in V2 and V3, you get a little bit more leeway. So females have to have at least 1.5 millimeters of elevation. Males less than 40 get 2.5 millimeters, and males greater than 40 get 2. All right, so a little bit about the anatomy, which Dr. Ferguson talked about a little bit. So you have this, say this is your left ventricle here. Here's your aortic valve, and your coronaries are coming off of your aortic valve here, or right past your aortic valve. So you have your left coronary artery, your right coronary artery. Your left coronary artery gives rise to your LAD, or your left anterior descending, and then your circumflex that starts wrapping around to the back of the heart. And your right coronary also goes around to the back of the heart. All right, so for injury patterns, we look at it this way. So for laterally, we look at 1 AVL, V5, V6. So you get any 2 of those leads. If you have ST elevation, it's a STEMI. Inferior 2, 3 in AVF, and then septal V1, V2, and then anterior V3, V4. Some people learn this pneumatic as the mnemonic Sally, which I had not learned before. But if you can't remember it, that's a good way to remember it. This is the image that Dr. Ferguson had. So you have your aorta, you have your right coronary coming around, 2, 3 in AVF. You have your LAD going anterior septal. You have your circumflex going V5, V6, and then over here 1 in AVL. And then, y'all heard of reciprocal changes before? Yeah, so if you have ST elevation and like 2, 3 in AVF, sometimes you'll see ST depression in other leads. So this is an easy way to remember it, which I had actually never heard of until I prepared this lecture. But if you use the word pales, you can use this for reciprocal changes. So if you have a STEMI inferiorly, you can look for reciprocal ST depression laterally and anteriorly. Or if you have a lateral MI, you can look inferior septal. That's the easy way to remember it. All right. And so what does a STEMI look like on an EKG? So sometimes you'll get to a patient, they have chest pain, sounds very classic, crushing chest pain, I feel short of breath, I'm having vomiting, I'm real sweaty. And their EKG might be normal. They might get to the hospital and then they might have hyperacute T waves. Sometimes this can look like hyperkalemia, but a lot of times this will be before that ST elevation. Sometimes, if they sit at home and they're like thinking the chest pain's going to go away, and you get to them and you already see the tombstones, that ST elevation. Later on, they'll start developing a Q wave, and then their T wave will flip. So they'll get a T wave inversion, and then it'll get better over time. All right, so let's look at some EKG. So STEMI or no STEMI? STEMI, yeah. So where we got elevations? Yeah. So 2, 3 in AVF. Do y'all see any reciprocal changes? Yeah. So 1 AVL. You see those S2 depressions, which makes sense. So inferior would have lateral reciprocal changes, right? Okay, what about this one? STEMI or no STEMI? Yeah. Yeah, definitely lateral. VC1 is up, AVL, and then V5 looks up, maybe a little bit V6. And then you see your reciprocal T3 and AVF are depressed. But then also you can see depressions V1 through V3. All right, what about this one? It's like tombstones. Anybody? Yeah, so lateral definitely, 1 AVL, but then also here, right? So I could have told you this is a 44-year-old male, right? but he still has more than 2.5 millimeters, right? So I would say, yeah, so that's septal, anterior, and lateral. So that's a pretty high occlusion, right? If it's getting all those vessels. And then you see your reciprocal inferior changes. All right, one more, and I'll just do this one. This one is just the anterior septal. All right, so we'll talk about some special things. This is, Dr. Ferguson talked about this, but you worry about, especially with the inferior STEMI, that a patient could have RV involvement or right ventricular involvement. The concern with that is that these patients get hypotensive really quick. So think if you give them a nitro, you're going to dilate all their vessels, right? So they're not going to get enough blood back to the heart. And then their RV is not going to be able to pump it out, because if that RV is infarcted, it's not going to be able to pump. And so then they're going to get really hypotensive. So we worry about inferior STEMIs having RV involvement. That only happens about 40% of the time. But these patients usually need IV fluids, not nitro. If that patient has an inferior STEMI and their blood pressure is 160/110, yeah, give them a nitro. It's probably not going to hurt them. I'd maybe have an IV before you give it, or while you're giving it, you get an IV, but that'll be okay. Things that make you think more that they're going to have RV involvement are if they have an inferior MI, so they have ST elevation 2, 3, and AVF, but then they also have elevations in V1 or ST depression in V2. That's highly specific for an RV infarct. Or if their ST elevation is greater in 3 than 2. And what we can do to diagnose this is a right-sided EKG. We don't do these a lot in the hospital, and it would be hard. Maybe while you're on scene before transport gets there, you could do this, but it would be hard to do this in the back of a rescue, I think. But what you do, you essentially move your precordial leads to the right side of the chest. The most specific one that you'll want to look at is V4. So say you have this EKG initially, so you have elevations in 2, 3, and AVF, and you think, oh crap, it's an inferior MI. But then you realize 3 is greater than 2. You see this elevation is more than this one. And then they have some elevation in V1. So you think maybe they're having an RV involvement. You get a right-sided EKG, or you can really just move V4 far. And you see the elevation here. That tells you that it has RV involvement. Or you could just be careful with inferior MIs and not give them nitro if they're borderline, right? This is just for style points. Okay, posterior MIs, Dr. Ferguson also talked about these. So that's when you get infarction of that back of the heart, so the posterior myocardial tissue. It's usually supplied by the posterior descending artery. So usually that's a branch of your RCA. So your right coronary is coming around, and it gives rise to this posterior descending artery. So in 80% of people, it's from the right coronary. It can be from your circumflex that's going around, but most of the time it's from your right coronary. And usually these are associated with the inferior MI. And so what we're going to look for is ST depressions in the septal and the anterior lead, so V1 through V4. And why you're seeing that, because basically that EKG is seeing the heart attack backwards, essentially. That's why you're seeing that depression. So you can do a posterior EKG, and you would see elevations in the posterior leads. And this is how you do it. You just move V4 through 6 to the back and make it V7, V8, V9. So if you had this EKG, so you have elevations in 2, 3, and AVF, and then you see these depressions in V2, V3, V1, and probably V4. So you think, oh crap, I also have a posterior MI. You could do a posterior EKG, and you see the elevations in the posterior lead 7, 8, and 9. And also for style points, what you can also do is take your EKG and flip it upside down. And when you have elevations in 1, 2, 3, and 4, then you worry about posterior MI. And that's what most people do. All right. The left bundles, we'll talk about scarbosa a little bit more in depth. So for the left bundle, so normally you have conduction going down your right bundle, your left bundle at the same time. But if for some reason you have something blocking it, It will go down your right bundle first and then move over to your left ventricle. So to diagnose this, your QRS has to be wide, so greater than 120 milliseconds. And then you'll have this downward S wave in V1. So there's other criteria that you can look for, but I'm with Dr. Ferguson that this is the easiest way to figure out if it's a left bundle. Is it wide? And look at V1, and if it's downgoing, it's a left bundle. So diagnosing an MI or a STEMI in a left bundle can be really difficult, especially if the life pack's not going to tell you. It's going to see left. So we got to know about Scarposa criteria. So if you have something that looks like this, so discoordinate. So what I mean by discoordinate is your QRS is going up. Gotta blow that off. Okay. So your QRS is going up and your ST segment T wave is going down. So that's discoordinate. So one's going one way, one's going the other way. And same for other leads. If they have a downward QRS, they have an upward T wave. All right, so this would be, you would think, normal. So you have a down QRS, an up T wave, down QRS. But then when should we start worrying about a STEMI? So this is Scarposa criteria. I'll be honest, when I have a left bundle, usually I'll pull this up on my phone because I can remember this, but then I'm like, how many points is this? Did I really remember it correctly? So just have a picture of it saved on your phone in your favorites, and then you'll know. So what you're going to look for, so you can have concordant ST elevation greater than 1 millimeter in leads with a positive QRS complex. So if their QRS is up and they have a positive ST segment elevation here, then that's a STEMI. So it's concordant, so it's going the same way. Or if they have concordant ST depression in V1 through V3. So you have this downward QRS, that ST segment is depressed, right? So that's more than 1 millimeter, so they get points for that too. Or if you have discordant ST elevation greater than 5 millimeters. All right, so let's look at the CKG. What do y'all think about it? So it's wide, right? So we think left bundle. We can look at V1 and it's down going. So we know it's a left bundle, right? All right, I'll look closer straight on. So y'all see this here. So remember V1, V2, and V3, if you have discordant depression or concordant depression, the QRS is down, ST depression, then that's a STEMI, right? Y'all see that? It's tricky, huh? Okay, what about this one? This one I think is a little bit easier. So we think it's wide. We go over here to V1, it's down, so left bundle. Or y'all see a problem there. You can do a systematic, like if you had a left bundle or a ventricular paced rhythm. I forgot to mention that. I think this one is actually ventricular paced. But if you have this pulled up on your phone and you start just going through it, so let me look for these. So I'll look for that concordant ST elevation. So if I look in 1, AVL, 5 and 6, hard to tell maybe here. But then what about 2, 3, and AVF? Yeah, so there's that concordant ST elevation. So that's a STEMI. And your life pack's not going to catch that, right? So we don't want that patient, if whoever transports them, to be sitting on a wall for 4 hours. All right, so now we're going to talk, any questions about left bundles? I know that was a lot. I think having a picture of it on your phone is really helpful because that's a lot to remember. I mean, I look at EKGs all day, and that's a lot to remember. So now we'll talk about DeWinters and Wellens. So these are kind of more fun things to talk about, but to be honest, I've never seen this before. But it's very interesting, and if you catch it, you can save somebody's life. So DeWinters is an anterior STEMI equivalent. So it doesn't have any ST elevation, but it's actually a STEMI. So it happens in about 2% of an acute left anterior descending artery occlusion. You may see ST elevation afterward or before you see this de Winter pattern, but a lot of times you're not going to. So what it is, so you have these tall, prominent T waves in your precordial leads. So think V1 through V4. So you have these tall T waves with an upsloping ST depression. So you have this ST depression here that's upsloping, and you have this tall T wave. And then a lot of times you'll also have some upsloping ST elevation in AVR. This is actually a STEMI equivalent. So if somebody came into the ER and somebody wasn't really paying attention and missed this, that person could like drop dead, right? A high LAD occlusion can kill somebody pretty quick. All right, so looking at this EKG, so we're looking at the precordial leads, right? So if you see here, you have ST depression, right? So there's your baseline. And then you have this upsloping ST depression with a tall T wave. So this is somebody that if I had this EKG, I would call cardiology, activate the cath lab because they need to go. And if cardiology told me, nah, we're good, then that's on them, right? That's not on us. We don't want to miss this. Here's another one. So same thing. Here's your baseline. You see that ST depression, upsloping with a high T wave. All right, a little bit about Wellens. So Wellens is not a STEMI equivalent. Why I think it's important to talk about this is that if you see Wellens, it's really specific for critical stenosis of their LAD. These patients don't need to go emergently to the cath lab. But the problem with this is if they have a patient who is admitted for chest pain and they have an EKG that looks like Wellens, hospitalists might not realize, like the hospitalist service might not realize it. They'll order a stress test on this patient, and that patient's going to drop dead during the stress test, right? So these patients need to be cathed because they have bad stenosis of their LAD. They don't need to go exert themselves to then get no blood flow to their heart, right? These patients need to be cathed. So what you can look for are a biphasic T wave, so that T wave goes up and then down, or a deeply inverted T wave. And this is only in V2, V3. Usually when you'll see this is you'll have a patient who had chest pain and now their chest pain's gone. Or, I have an EKG for this. You have a patient that had chest pain with EMS. You got this EKG. You said, oh crap, right? Worried. Then they get to the hospital and this is their EKG. ST elevation's gone, right? But they have this biphasic T wave. So this person could inadvertently get admitted to hospitalist service and then, or a general medicine service, and then they could die if they got a stress test. So here's some other EKGs that show this. The biphasic T wave, V2, V3, or that deeply inverted T wave. All right, so what are we gonna do for these patients? So in a pre-hospital setting, we really wanna make sure that we can identify those patients who have ACS. We try to make their symptoms better if they're hypertensive or if not inferior or they're not borderline hypotensive. We can give them nitro. We wanna make sure we give them an aspirin. And then we wanna make sure we take them to the right hospital, right? We wanna make sure whoever's transporting for you knows this is a STEMI, that they go to the right place, right? We don't want them to sit on a wall for 4 hours and die for something that we could have caught, right? So what do we do in the hospital? So for STEMIs, the primary treatment for these people is PCI. So they'll go into an artery, usually in the groin or the wrist, and they'll go up to the coronary arteries and try to reopen that blood vessel. The goal is to do this in less than 90 minutes. sometimes in rural Alabama, or if you're waiting on transport, you can't get them somewhere in 90 minutes, right? So if it's going to be greater than 90 minutes, our goal, or greater than 120 minutes, what we do is slice these people. So we give them thrombolytics like TPA, TNK, and then they get CAFed when they get to a PCI center. Okay. So if it's going to be greater than 90 minutes, then we want to give them medicines to lyse them to try to open up that blood vessel. But the caveat to that is that we try to give them lytics within 30 minutes. All right, so other things we can do. So things y'all can do, ask for nitro, oxygen to pre-oxygenate them in case they decompensate. And things we'll do in the hospital are give them antiplatelets like Plavix or Brilinta. I'm sure y'all have had patients that have been on those. And a lot of times we'll give them a heparin bolus, which is an anticoagulant. For STEMIs, so STEMIs are those patients who have a great story. They get to the hospital, but their EKG looks okay. Maybe they have some ST depressions. They get to the hospital, their troponins are elevated. These people need to be cathed, but they don't need to be cathed right now, okay? So if it's 2 a.m. in the morning, a cardiologist is not going to come in to cath them. They might schedule it for the next morning because they have disease. We need to see what's wrong with them, but we don't need to do it emergently. There's not enough cardiologists to do that. But so what we'll do for them are kind of give them the same therapies that we would for STEMIs, but we usually put them on an anticoagulant like a heparin drip, or we'll give them Lovenox shots. All right, so we're gonna go through a couple cases. These are actual cases. We have some pre-hospital EKGs, hospital EKGs, and cath reports. And these are some recent cases for the BRIMS area. So first case, you have a 57-year-old male, no known past medical history, who presented with chest pain, went to the left arm and the jaw, said he works night shift, said he woke up kind of feeling fatigued, but otherwise felt okay, went to work, then started unloading pallets, and he started getting chest pain, short of breath, and just didn't feel good. So he called EMS. So y'all get to him, y'all get this EKG. So what do y'all think? Yeah, inferior. So you said, oh crap, you're having a heart attack, sir. So ST elevations 2, 3, and AVF, right? And then you can see maybe some depressions here, reciprocal, maybe here, here. Then he appropriately gets to a PCI center. So this is when he got to UAB. So this is his repeat EKG, looks the same, 2, 3, and AVF, depressions, maybe some worse depressions here, right? So he goes and gets cath. So this is his cath. So inferior, we think right coronary, right? And so this is a catheter shooting dye into his coronary blood vessels. You see it kind of cuts off right here. So that's where he had an occlusion. So they go in and they put a stent in there and they open it back up. So now he's got good blood flow. So this guy had 95% stenosis of his right coronary. And what DES is a drug-eluting stent. Pretty cool. All right, it's another one. We had a 76-year-old male, past medical history of high blood pressure, high cholesterol, came in with chest pain for 2.5 hours. This is the EKG. What do y'all do when y'all see this? Pray about it? So what I would do is say, oh crap, give him an aspirin, probably give him a nitro, put the pads on him, and make sure you got transport on the way, right? So there's huge elevations, right? 1 AVL, V5, V6 may look okay, but then you got these tombstones here, classic STEMI. So he didn't even get another EKG when he got to the hospital. So they sent this in to the hospital. We said, this is terrible. We're calling in the cath lab. We didn't get another one. So usually we'll get a repeat EKG just so we have it in our system. But if it's going to prevent him from getting up to the cath lab, then we don't, it doesn't matter, right? But this guy, you see, so big anterior, some lateral involvement. That's a big MI, right? So this guy was really sick. So he was hypoxic. They had to put him on CPAP on the way to the hospital. I think we put him on, changed him over to BiPAP in the hospital. He got up to the cath lab and actually got intubated because he was so sick. And they put an Impella device in. Y'all ever heard of an Impella? Yeah, so it's this device. So they usually put him in prior to a cath. So what it does is essentially it's pulling blood from your left ventricle and pushing it out your aorta. Because basically this is that area of the heart that's not getting perfused. So it's not working right. So this is just to help move that blood along while they're cathing and trying to open up that blood vessel. It's pretty cool. So this was his cath after he got his Impella. So he had this abrupt stop right here. That's his LAD. Had 100% stenosis. Put a stent in and opened that vessel right back up. All right. So this is the last case, and I think probably one of the most important ones. So this is a 61-year-old male, past medical history of diabetes, high cholesterol, who came in with shortness of breath. Said, I just feel very short of breath when I lie down. So you probably think, oh, do you have CHF? Do you have a pneumonia? The guy actually thought he had COVID, tried to wait out his symptoms at home, as most people do. Then it got so bad he called 911. There was not an EKG done because he had shortness of breath, right? Sounds like CHF. This is the important thing. So this is his EKG when he got to the hospital. What do y'all see here? This one's a little more subtle. Y'all see that? So he's got these ST elevations, 2, 3 AVF. So he's having an inferior MI. And this guy, I don't know what the delay in care was, but you know, if we hadn't, hopefully they got an EKG pretty quick. At least our ER is usually pretty good about getting EKGs on shortness of breath, but he could have been sitting on a wall for 4 hours, right? And God, it could have developed heart failure because he didn't get reperfused. So I think the big thing about this is if you think this could ever potentially be a heart attack or ever potentially be cardiac, and anybody with shortness of breath, there's probably a 50% chance that it's cardiac, is to get an EKG. So this guy had 100% stenosis of his right coronary artery. You see it abruptly stops here. They put a stent in and open it back up. All right, that's all. Any questions from anybody? I think the important things are, if you think that it could be cardiac at all, get an EKG, because what you do can save somebody's life, right? Because I might not see them for 4 hours, right? Our ER, if y'all didn't get an EKG, our ER might not think about getting an EKG either.
Great lecture, Dr. Brown. We actually do have quite a few questions came in online.
Boy.
Yep. So the first one is can you explain and describe Osborne waves that are associated with ischemia?
Osborne waves are usually associated with hypothermia. And I'd have to pull up a picture to show y'all because it looks very specific. But I can do that if you want me to. Usually they're associated with hypothermia.
So usually associated with hypothermia.
Yeah.
So what about the other abnormal waves? I think people are confused about how they're labeled, Q prime, and I think there's some other things, some literature. Any of that important to us?
It can be, but I think the things that are in this lecture are probably the most important things. Whenever you start getting into the weeds of it, there's a lot of things I think to remember, right? What do you think, Dr. Ferguson? I mean, there's a lot more cardiac we could talk about if we wanted to.
I agree that we talked earlier, remember, about that EKG is a screening tool for badness, right? So you can get way deep in the woods with this. The cardiologist can look at EKG and say, oh, yes, his left atrium has a 2 millimeter. Like, I don't have a clue what you're saying, sir, right? So that stuff for us, the points I would think is recognizing dysrhythmias, recognizing STEMIs, hyperkalemia, and the things that Dr. Brown talked about, things that matter right now, okay, that impact patient care. So
like, I think the important things about STEMIs are we have a treatment for it, right? We can take these people to the cath lab, we can open up their blood vessel, try to reperfuse their heart so then they don't go into cardiac failure. They don't need a LVAD. They don't need a heart transplant down the road. So that's something we can treat right now.
Right. They can go back to work, live a normal life potentially from that.
Yeah.
You know, the Osborne wave, like you said, again, it's hypothermia. It's a little notch between the QRS and the T wave. It's kind of hard to describe it. You can Google that, but again, it doesn't change. Hey, somebody just called me. It doesn't change patient care. I took a few notes too. I was going to ask a few things. That's okay, Chief. Or not ask, but the Scarbosa criteria that Dr. Brown mentioned, you can use that on paced EKGs as well. Somebody with a pacemaker, she had one up there. We used to talk about if you have a paced rhythm, you can't interpret it. That's junk. You can use Scarbosa to look at somebody who's got a paced rhythm and say, okay, you have underlying ischemia. This is bad. Okay. You can also pick up hyperkalemia on a paced rhythm. There are some new point of care devices. We usually get this question as well. We may have about troponin, the blood test that we use for cardiac. There are some point of care devices out there that potentially could be beneficial now. Troponin pops up within an hour and a half to 2 hours. The problem is the state regulates all labs, and it's going to be pretty costly to run those. But if you're interested, something to talk to your medical director about. Documentation of EKGs. Are y'all getting feedback in this area when y'all take a patient in that has a abnormal EKG or chest pain? Y'all get feedback? Do they go to cath lab? What happened to them? So that's something you may want to push in your area. I know that in the past, obviously EMS is the stepchild of all healthcare. I get it. Okay, guys, I'm with you, right? But the hospitals are getting these metrics now where they have to meet certain metrics that include EMS documentation now. So we have a little bit of a foothold to kind of not demand, but to politely request feedback on our patients, whether you transport or not. So if you have a hospital that participates in the STEMI system at the national AHA level, they have to have that first patient contact time and the first EKG contact or first EKG done. So that's things they have to get from you guys, whether you be the transporting or not transporting. So it's something you could probably negotiate to get follow-up. Because if you don't have feedback on these EKGs, you never learn from them. So that's something to think about. And that's all I had.
So thank you. We've got another question is, can you describe the pain that radiates down the arm during the MI and kind of, do we know what the source of that is? Why it makes people's arm hurt?
I mean, I feel like the pain could be described as, I mean, some people say they have jolts of pain down their arm. Some people say they have numbness or tingling down their arm, but I don't really know specifically what's causing it unless they're just nerves.
Yeah, just referred pain from, or whatever. So, you know, classically, the story we learned, chest pain, shortness of breath, diaphoresis, clutching over is a STEMI. Would it be defined as classic in healthcare? That means 25% of the people that have that symptom have to have those symptoms. So that means that 75% of the people having a STEMI are not having chest pain, crushing, bending over, feeling bad. So like you said, nausea, vomiting, weakness. If you're a diabetic, you don't have the same nerve sensory fiber, so you may not have pain. And a person that's 80, if they say, I just don't feel right, guess what? They get an EKG because they're freaking old. You just don't know what's going on with it. Again, EKG, don't get caught in the woods. It's a screening tool. STEMI, no STEMI. If the rate's too slow or too fast, use that to interpret it and figure out what to do with the patient. So
what you care about is this EKG going to kill this patient while they're with me or in the next hour?
Yeah. Yep. Good. So we had another question that was texted to me. Why are diabetics not candidates for PCI?
They are candidates for PCI. I would say probably the majority of patients who get PCI are diabetic.
Yeah. So I think people that don't get PCI, if you have bad kidneys, if you're on the verge of dialysis and we squirt you with contrast, that can hurt your kidneys and put you over the edge. So we have to weigh that risk to benefit. If we think you're going to die from your STEMI, your heart attack, then you get the contrast and we roll the dice to see if your kidneys survive or not.
We can fix your kidneys with dialysis.
Exactly.
There's not a lot of heart transplants.
Yeah, so it's all risk to benefit. If you have someone who is mentally mentally unstable, and you know they're not going to take blood thinners, those people we can't do a catheter and put a stent in them, because if you don't give somebody blood thinners for the first 6 weeks, 3 months after a stent, that vessel will reocclude and they'll freaking die. So if I have somebody who has uncontrolled schizophrenia, bad dementia, and they aren't going to take their medicines, then we can't do a PCI, put a stent in them. We can go in and balloon them up and open that vessel and hope it doesn't reocclude, but we can't put stents in those people because they can't take the medicine. So there are risks to this procedure, but for the most part, we can fix most of these things if we catch it in time.
I think that another point would be if a patient has such bad occlusions or such bad disease, sometimes they'll keep them in the hospital and eventually get a cabbage or an open heart surgery instead.
Gotcha. Thanks. So we actually had a couple people ask this. I published one of them for everybody to see, but the question is can we get a copy of your PowerPoints or slide deck sent to us?
Yes.
So the answer is yes, but I want everybody to know that these sessions are recorded after a week or so, sometimes longer. They appear on YouTube, so check out our YouTube channel. It's Alabama EMS Challenge on YouTube. You can actually go to the description of the videos, click a link, take a test. When you make 100 on the test, you can get distributive Con Ed credit that counts for National Registry by doing that. So yes, to get the slide deck, you can email, I guess, me, wward@centerpointfire.com, and I can help facilitate that for you. I hesitate to do that because I don't want 200 people asking for it, but we'll do it within reason, as Dr. Ferguson would say. Hey, thanks everybody for being here. Thanks, Dr. Brown, for a great lecture. Dr. Ferguson, as always. In June, we're going to be at Centerpoint Fire on June the 15th. We're just going to have one session in June. So we've got World Games coming to Birmingham. Everybody's kind of busy, so we usually do one session in Centerpoint, one session somewhere else in the state, but we're going to have a staycation in June for EMS Challenge. We're going to do the lecture and skills lab at Centerpoint Fire on June the 15th. And you got anything else, Doc? Cadaver Lab in August. Stay tuned for the dates. And I think that's a wrap. Thanks everybody for being here. If you're here locally in Opelika, come and join us. We got lunch coming at about 11:30, and then we're going to have a skills lab until 12:30 with the docs. So hope to see you there.